Good, good evening, students. Today I'm going to take the topic on hepatosplenomegaly with Paler. So to start with demography, Anant is a 4.5-year-old male born out of third degree consanguinity, hailing from Uttar Pradesh, informant being mother, and the information is reliable. Here, demography is very important with regards to hemolytic anemias, because consanguinity, most of the recessive disorders like thalassemia, sickle cell disorder, or consanguinity is very important. Race is also very important with hemolytic anemias. Thalassemias are common among Sindhis, Parsis, Muslims, Punjabis, and sickle cell is common among tribal people. So race and hemolytic anemia is important. Similarly, age. So remember, the switch to beta chains happen at 6 months. So thalassemia and sickle cell anemia starts presenting after 6 months. That is 3 to 6 months and after. But G6PD spherocytosis can present right from the birth. So they present with neonatal jaundice, G6PD deficiency, as well as spherocytosis. With regards to 6, X-linked inheritance will be G6PD deficiency. And thalassemia intermedia will have a later presentation. So beyond 2 years only they present with the presentation. So demographic details is very important with hemolytic anemias. Coming to the presenting complaints, remember, when you're dealing with a chronic problem which has a lot of episodes, for example thalassemia, you have a lot of transfusions, better to start from the beginning rather than the present episode. Start from the beginning. And most often the thalassemia and hemolytic anemias presents with pallor and non-specific symptoms of pallor like easy fatigability. And if the pallor is more, they can present with CHF, with history of recurrent transfusion history. Sometimes splenomegaly symptom, they can present with abdominal symptoms. Okay, so here our case is presenting with pallor since 4 years on regular blood transfusion since then. Distension of abdomen for 3 years, and associated cough coryza since 7 days. Okay, and coming to the elaboration of the history of presenting illness. Anant is a known case of blood disorder. Do not say straight away that it's a case of thalassemia. A known case of blood disorder on regular blood transfusion. Initially presented at 7 months of age when mother noticed progressive pallor, decreased activity, and fast breathing. So it start with how all it started, the age when it started. So is it 6 months? Very important. That is the time period when there is the switch from the gamma chains to the beta chains to the adult hemoglobin. So 6 months. So that age of presentation is important. So elaborate from that age. Age of transfusion, as I said already, the thalassemia intermedia will present later on beyond 2 years of age. Okay. He came to the hospital and the child was given blood transfusion. Based on the blood testing, he was diagnosed with some blood disorder, because most of the parents don't say that the child has thalassemia. They will say that it's a blood disorder requiring recurrent transfusion. Then elaborate the transfusion schedule. Uh, you have to elaborate how often the child is taking transfusion, any change in pattern of transfusion. Okay, if transfusion is adequate, the hemoglobin is usually maintained at 9 to 10 percentage, so the child should not present with pallor often. So when you have monthly regular transfusions, the child will not present with pallor symptoms. But if the requirement is transfusion is increasing, then it suggests hyperplanism. So here in our child also same thing is happening. Since the child is receiving blood transfusion almost every month, and now he is requiring blood transfusion once in every 2 to 3 weeks, the frequency has increased. And child is recently often complaining of easy fatigability on exertion and pallor in spite of getting blood transfusion, which suggests that hypersplenism is developing. Then mother also noticed the distension of abdomen, especially upper part of the abdomen, by 2 years. First on the left side, and then it has increased even to the right side. This distension has increased, so which is suggestive of splenomegaly. So splenomegaly is the place where the RBCs get destroyed. So in extravascular hemolytic anemia, you get splenomegaly, and also it is the place of extramedullary hematopoiesis. So splenomegaly is an important symptom. They present with abdominal symptoms, also easy satiety because of the swelling. Okay. Patient also has cough coryza for 7 days. Cough is non-productive, non-spasmodic with diurnal or postural variation. Cough is associated with coryza. So associated symptoms like minor illness can be there, not an issue. Negative history is very important. Okay. So you have a differential diagnosis for recurrent blood transfusion. It could be thalassemia, it could be spirocytosis, it could be sickle cell with CNS manifestation like stroke, where you need to give regular transfusion, or it could be enzymopathies like G6PD deficiency, diamond blackfan, where bone marrow failure is there. So these are all requiring recurrent blood transfusion, not just thalassemia. You have spirocytosis, sickle cell with the CNS manifestation, enzymopathies, and diamond blackfan. So you have to ask questions to rule out such conditions. So no painful episodes of limbs, swollen hands, abdominal pain, and convulsions suggestive of sickle cell disease. History of jaundice is there, very mild yellow eyes. There is no yellowish discoloration of the urine. No history of worsening with drug intake or infections, which is suggestive of G6PD deficiency when there is worsening with drug intake or infections. And also, you have to always rule out nutritional causes of anemia. No history of pica like eating mud, dirt, which is highly suggestive of iron deficiency anemia. No history of worm in the stools. No history of recurrent loose stools suggestive of malabsorption symptoms like celiac disease, where iron deficiency anemia is common. Rule out infectious cause of hemolytic anemia. For example, no history of fever with chills suggestive of malaria. And make sure that once pallor is there in the negative history, other marrow elements are fine or not. Okay. So no history of bleeding from any sides, any other sides. No history of fever or bone pain or neck swelling suggestive of leukemias. Okay, or suggestive of any WBC problem. Okay, so other marrow elements are very important. Similarly, in hypersplenism, not only anemia will be there, there will be also thrombocytopenia and decrease in WBCs. So other three elements also will be affected. So no history of bleeding from any sides, no history of fever, bone pains, and neck swelling. Similarly, complications of thalassemia, no history of CHF symptoms, no history of irritability, lethargy, breathlessness, fast breathing, edema of the feet. If the child is small, no history of any feeding difficulties, no history of failure to thrive, suggestive of CHF symptoms. And finally, the most important complication of thalassemia will be your iron overload, causing your diabetes. Okay, so no history of polyuria, polyphagia. Okay, and it will affect the growth. Okay, so pituitary might be affected in iron overload, or if the transfusion was not good, the child might be shorter. So history of shorter than his friends. No history of polyuria or polyphagia. Okay. And if the child is a bigger child, always ask related to the puberty related history, whether there is any delay in puberty or not. So a lot of negative history is very important in hemolytic anemia. Okay, coming to the past history, no history of any other illness in the past other than this present condition. No history of any surgery in the past, very important. They might have undergone surgery for splenectomy if hypersplenism is there, or gallstones are there, pigment stones are there in spirocytosis, then cholecystectomy. So that history is very important. No history of contact with TB. Okay, and treatment history is very important. Other than the transfusion, any drugs is going on or not. So here the child is on regular oral medication, taking in empty stomach in the morning along with milk, which is very suggestive of chelation therapy. Whenever iron overload is suspected, we give chelation therapy. When was it started? It was started at 2 years of age. Also other medications, but mother may not be able to tell. So it could be folic acid, it could be hydroxyurea. So when it was started, how is it given, whether it is oral chelator, or whether it is injections. All these questions you have to ask with regards to the treatment history. Then coming to the birth history, antenatal history, uh, sometimes alpha thalassemias and RH incompatibilities start presenting in antenatal period itself as fetal head drops. So antenatal history is important. So it was a booked case. TT was taken, iron and folic acid was taken, no fever, no rash, radiation or drug intake, no pregnancy related complications, anomaly scan was normal. If any history suggestive of fetal hydrops is there or not, you have to ask in the antenatal history. Natal history, the child is a full-term LSCS, immediately cried after birth, birth weight was good, no NICU admission was there initially. So breastfeeding was initiated soon after birth. What is more important is the postnatal history. History of neonatal jaundice, so high that requiring exchange transfusion. Sometimes hereditary spherocytosis and G6PD deficiencies can present with severe jaundice, neonatal jaundice requiring even exchange transfusion. But the common is common. Blood group incompatibilities, the RH incompatibility is common cause for neonatal jaundice. But if there is history of recurrent transfusion along with neonatal jaundice, think spherocytosis or enzymopathies. Okay, so here no neonatal jaundice requiring phototherapy, and the baby was given exclusive breastfeeding for 6 months. Coming to the developmental history, here development was normal, but if they ask you which condition, hemolytic anemia, which condition development might be affected, the Gaucher's disease. So remember the storage disorders where you get splenomegaly, hepatomegaly, storage disorder, where due to bone marrow infiltration you can get anemia. So Gaucher's disease. Okay, and nutrition history is very important. We have to see how is the iron intake, whether there is a folate intake is there or not, whether the child eats green leafy vegetables. Here he eats less amount. He consumes 1300 calories and 12 to 15 grams of protein. Find out the deficit percentage here, how whether there is any deficit. How is the iron intake, whether the child is non-vegetarian, he takes non-veg items. But if the child is on strict milk-based diet and nutritional anemia, so it's deficient in iron. So iron deficiency anemia is common with milk-based diet. Strict vegetarians, they have problem with B12 deficiencies. So this all you have to ask. Whether the child is using any iron utensils, already thalassemia, they are prone for iron overload, so they should not take iron utensils. Some they might recommend taking tea intake. Tannins prevent in iron absorption. So children with thalassemia may be encouraged to take tea and citrus fruits. And coming to the immunization history, very important whether immunized up to date for as per the universal immunization schedule. But more important will be the hepatitis B vaccine, because they're given a lot of blood transfusions. We have to protect them from hepatitis B. Hepatitis A vaccine has been given or not. And if splenectomy is planned, we have to protect from encapsulated organisms like Haemophilus influenza, pneumococcal, and meningococcal. Okay, so make sure that those vaccines have been taken or not. Family history, anybody else in the family, any surgeries have been done previously, like cholecystectomy, splenectomy, history of gallstones, history of jaundice, blood transfusion, very important, especially for autosomal dominant conditions like hereditary spherocytosis. Family history is very important. Okay, so here there is consanguinity is there, but no other family members are receiving any transfusion or jaundice. Okay, and socioeconomic history is important too, because here the child is getting the recurrent blood transfusion. We need to know the economy of the economical background of the family. And in nutritional deficiencies, so the socioeconomic history is very important. Okay, so here he belongs to the class 2, that is the upper middle class according to the Kupuswamy scale. So summary is a 4.5-year-old male child born to third degree consanguineous marriage presents with a hematological disorder. Don't straight away say with thalassemia. Hematological disorder requiring regular transfusion since the age of 6 months, recently requiring more frequent transfusions, probably suggestive of hypersplenism, and child is often being symptomatic due to pallor. Child is also on oral medications, could be chelation therapy, and family belongs to the upper middle class. Child born out of third degree consanguinity, autosomal recessive conditions are common, with adequate calorie intake, attained normal milestones, and immunized as per the universal immunization schedule. Probably we are dealing with thalassemia because from the 6 months of age, transfusion has started, and now the child is developing hypersplenism. And I would like to do abdominal examination and a general examination to confirm further the diagnosis. Okay, so general examination, the child is conscious, oriented, cooperative. Anthropometry, very important. Make sure that the anthropometry is fine, because hypoxemia and inadequate transfusion, the growth is going to get affected. or if there is iron overload affecting the pituitary, short stature can be there because of hypopituitarism. Okay, and vitals, you just do the regular vitals, but what is more important is the pallor causing the tachycardia and features suggestive of CHF, where JVP might be elevated. Okay, so here the pulse rate, respiratory rate, pulse rate is on the higher side, 110 per minute, and otherwise it's fine. And okay, so head to toe examination. Okay, so very important head to toe examination. You have to document the hemolytic phases. So you have frontal basing, malar prominence, dental malocclusion. These are all hemolytic phases because of the enlargement of the bone marrowic spaces, the diploe, because of the increase in the erythropoiesis. Okay, and child is alert, playful, and interactive, and there is severe pallor here in spite of the regular transfusion, so which is suggestive of again hypersplenism. There is mild icterus in spite of it being a hemolytic disorder. The icterus is very mild in thalassemia. So remember, the icterus is mild, you don't get a very marked icterus as seen in spherocytosis. This is because of the ineffective erythropoiesis. The RBCs lies inside the bone marrow itself before the heme is incorporated. So since the RBCs are lysing in the precursor stage itself before the heme is being incorporated, so since there is no heme incorporated, so the icterus is very less. So if there is frank jaundice, so remember, it could be because of your transfusion transmitted viruses like hepatitis C, hepatitis B, or because of the iron overload causing the liver disease. So frank jaundice is not common in thalassemia, and no clubbing, no cyanosis, pedal edema, or lymph node enlargement. And JVP is not elevated. In CHF, where pallor is high, JVP can be elevated. Then try to rule out other cell lines, so no petechiae, no purpurae. Ulcer in any other part, no ulcer in any part. Sickle cell will have ulcers. And pigmentation suggestive of iron overload, so see whether there is any pigmentation, and look for any upper limbs thumb abnormalities, forearm anomalies in the head to foot examination, because bone marrow failure syndromes like Diamond Blackman will have a triphalangeal thumb, okay, absent thumb. So they have these thumb anomalies and upper limb abnormalities. And if the child is a bigger child, more than 8 years, assess for the pubertal development, sexual maturity, make a basic assessment of the sexual maturity. It could be delayed, okay. Okay, coming to the abdominal examination, we mainly look for the hepatosplenomegaly, because hepatosplenomegaly is the place of extramedullary erythropoiesis. They might ask you how you are going to palpate the spleen, how to differentiate the spleen and the renal mass. So these questions they might ask, the standard question. So abdomen is distended, umbilicus is midline, slightly pushed downwards. No prominent veins, scars, sinuses, visible peristalsis. Quadrants are moving equally with respiration. Hernial orifice or normal, genitalia or normal. This is the standard you keep doing. Palpation is warm to touch, no tenderness present. Liver is palpable 3 centimeter below the costal margin, firm in consistency, margins are well defined, non-tender, and surface is smooth. Liver span is 8 centimeter, which is confirmed by your percussion. Okay, and there is also a mass in the left hypochondrium which is moving with respiration. So remember, it is firm in consistency, not bimanually palpable, not ballotable. So the renal swelling will be bimanual palpable and ballotable, but spleen will be not bimanually palpable, not ballotable. 6 centimeter below the costal margin, and it is if it is crossing the midline, suggestive of massive splenomegaly. Okay, and percussion, no free fluid, and liver span is confirmed. And auscultation, there is no bruit, ball zones are present and normal. So other systems, CVS, you might get a hemic murmur, and JVP might be raised. RS, the normal vesicular breath sounds, and CNS, higher mental function is normal, no sensory or motor deficit. So that's it. So summary, in addition to the history, you do the positive examination findings. On examination, he has a severe pallor and mild icterus, and he is not in heart failure, congestive failure. He has hemolytic phases. He has mild icterus, and splenohepatomegaly. Okay, he has splenohepatomegaly. So on examination, he has severe pallor, mild icterus, splenohepatomegaly, and hemolytic phases, and he is not in heart failure. So the diagnosis is, final diagnosis is, it's a case of hemolytic anemia, probably transfusion dependent thalassemia, and he is not in heart failure, but recent history is suggestive of hypersplenism, and he is on chelation therapy with normal growth and normal development. Okay, so what are the investigations you are going to do? So you start with the complete blood count. Okay, CBC, peripheral smear. So CBC, sometimes you have an increased total leukocyte count. They will ask you, how is it that is that suggests the infection? No. The because of the increased erythropoiesis, you will have nucleated RBCs, and nucleated RBCs, the counter counts it as leukocytes. So increased total leukocytes because of the increase in the nucleated RBCs, and it will be confirmed only by the peripheral smear. So in peripheral smear, so remember, it just resembles like your iron deficiency. You will have microcytic hypochromia, and anisopyclocytosis will be there. Something specific may not be so much specific, but common in thalassemia is your target cells. So target cells will be seen. Okay, and you are going to look for the reticulocytes. Any hemolytic anemia, reticulocytes will be elevated. But in thalassemia, so remember I said ineffective erythropoiesis. So the destruction happens in the precursor level before the reticulocytes are formed. So reticulocytes are not so much elevated in thalassemia as compared to other hemolytic anemias as in spherocytosis. So usually reticulocyte will not be elevated more than 8%. Okay, and you have your MCV, red cell indices like MCV, MCH, MCHC, all will be decreased similar to your iron deficiency anemia. And they might ask you about the red cell distribution width. So remember, in iron deficiency anemia, cells are of different sizes and shapes. So RDW will be increased, but in thalassemia trait, the same microcytic hypochromia will be there, but RDW will not be increased in thalassemia trait. So important differentiation between thalassemia trait and iron deficiency anemia will be your RDW. Okay, and coming to your serum bilirubin. So serum bilirubin, as I said already, it will be increased, but it will not be so elevated because destruction happens before the heme is being incorporated. And confirmation will be with your hemoglobin electrophoresis. A more better test will be your high performance liquid chromatography, which is a quantitative. Electrophoresis is a semi quantitative. And once you confirm thalassemia, you have to do for all family members to find out the carrier state, to find out the thalassemia trait, so that you can give the genetic counseling. You can do an radiology X-ray skull. Sometimes examiner will ask you for the hemolytic say, so you will have the hair on end appearance in the skull, and you do the serum iron studies, especially the ferritin levels, to decide on whether chelation has to be started or not. And Nestroff test, which is naked eye single tube red cell osmotic fragility test, it is a valuable screening tool for thalassemia where resources are limited. And to rule out other hemolytic anemia, so we do the Coombs test for autoimmune hemolytic anemia, and any hemolysis LDH will be increased. So these are the tests. And coming to some discussion points about hemolytic anemia, it starts with hemolysis. So whenever extravascular hemolysis happens, it happens in the spleen. So you will have a splenomegaly, and whenever hemolysis happens, you will have jaundice, and followed by, because of the hemolysis, erythropoiesis will start increasing, which results in expansion of the membranous bones, and that's why you'll have the hemolytic phases, the frontal bossing, the malar prominence, okay, the jaw occlusion, maul occlusion, so expansion of the membranous bones. And you will also have extra medullary erythropoiesis where the liver and the spleen increases, and because of this increased output, the reticulocytes are going to increase. But thalassemia alone will differ in all these features of hemolytic anemia, because the jaundice will be a bit on the lesser side, and reticulocytes will be on the lesser side because of the ineffective erythropoiesis as well. And they might ask you about the normal RBC span is around 100 plus 110 to 120 days. And different types of cells you might ask thalassemia. So remember the target cells, Bite cells and Heinz bodies are seen in G6PD deficiency. So target cells in hemoglobinopathies and Bite cells and Heinz bodies in G6PD deficiency. So why are you saying hemolytic anemia in this case? They might ask you. So here the child is having anemia, transfusion dependence in 6 months of age. 6 months is the age when the beta switchover happens. Other cell lines are okay. There is no fever. There is no bleeding tendencies. On examination, you are having the classical hemolytic phases. Pallor is there, jaundice is there, and hepatosplenomegaly is there. And that's why I'm considering hemolytic anemia. Okay. And coming to the discussion about thalassemia, you have an electrophoresis, and the normal hemoglobins are the adult hemoglobin, which is alpha 2 beta 2. More than 95% will be alpha 2 beta 2 HbA after the 6 months of age. You have the fetal hemoglobin alpha 2 gamma 2, which is less than 2.5%, and you have the HbA2, which is alpha 2 and delta 2 less than 3.5%. This will be the normal percentage, so remember that. What happens in transfusion dependent thalassemia or thalassemia major? In thalassemia major, the hemoglobin A will not be there because beta chains are not there, so no adult hemoglobin. So the hemoglobin F, fetal hemoglobin, will increase. So it's going to increase up to the range of 90%, and hemoglobin A2 also increases, and there will be less than 10% only of adult hemoglobin because the beta chains are not there. And in transfusion independent thalassemia, which is also called as thalassemia intermedia, there will be some hemoglobin, adult hemoglobin. It's not totally absent. So hemoglobin adult will be there, and hemoglobin A2 and F will be increased, but not to the level of the thalassemia major. Okay, so that's why they don't require transfusion, because some amount of adult hemoglobin is there, so they don't require transfusion often. Okay. And in thalassemia trait, everything will be normal except your hemoglobin A2, which would be more than 3.5%. So remember that in trait, hemoglobin A2 will be more than 3.5%. And remember, thalassemia is a quantity problem, whereas sickle cell is a quality problem. In thalassemia, the beta chains are absent. So the pathophysiology is beta chains are absent. So alpha chains alone are there, and they're going to become tetramers, and they're going to lyse the RBCs, and this lysis happens in the precursor level itself, and that's why ineffective erythropoiesis, since at the precursor level itself is happening, so the jaundice is not significant and the reticulocytes are also low. And depending upon the inheritance pattern, you have autosomal recessive, which is thalassemia and sickle cell disease. You have spirocytosis, which is an autosomal dominant, and it can present at birth itself. And G6PD deficiency is an X-linked recessive disorder present only in males, and it can present from the birth. Okay. And coming to a major discussion about the thalassemia major, this slide is very important. It's nowadays we call it as transfusion dependent thalassemia. It's not as thalassemia major, transfusion dependent thalassemia. They present after the switch over. So severe anemia from 3 months of age. They will have the hemolytic phases and hepatosplenomegaly. And transfusion therapy is the main treatment. So the goal is to maintain around 9 grams to 10 grams. So for that, we need to give transfusion of 10 to 15 ml per kg for every 3 to 4 weeks once. So transfusion has to be given, and it is packed RBC. What type of packed RBC, they might ask you? It is leukocyte depleted packed RBC. And this type of regime, we call that as a moderate transfusion regime. Here, we are not compromising the growth also. So growth has to be there. But at the same time, you should not over transfuse, resulting in iron overloading. Okay. There are other regimes like hypertransfusion regime, where you transfuse more often whenever the hemoglobin is, you maintain the hemoglobin more than 10, and you have super transfusion regime where you maintain the hemoglobin more than 12. But here the problem will be the iron overloading. So the balance will be to maintain hemoglobin just above around 9 to 10 hemoglobin, so that we don't go into the iron overloading. And so, because remember, they might ask you another question: how excess iron is excreted? Physiologically, our body doesn't have a mechanism to eliminate the excess iron. So remember that. And excess iron will result in hemosiderosis. That is the major complication for thalassemia. and you have your liver. It affects the liver, heart, and endocrine organs. Endocrine organs like your islet cells causing diabetes, pituitary, and the thyroid and parathyroid glands. Okay, parathyroid glands. And a point about when will you start chelation? Whenever iron overload. How will you know iron overload? Simple marker will be your ferritin level. So whenever it is more than 1000 nanogram per ml, we are going to start the chelation. Or sometimes they have a cutoff like start chelation before 3 years of age, or whenever the you have given 10 transfusions. So whenever you have done 10 transfusions, start chelation, or as early as before 3 years of age, you have to start chelation therapy when the ferritin level is more than 1000 nanogram per ml. And but what is the best indicator for iron overload? It will be T2 weighted MRI of the liver and the heart. That is the practical indicator, best indicator. But the invasive gold standard will be the biopsy to look for the liver iron concentration, but it is an invasive, so we don't do often. So best will be the T2 weighted MRI practically. And what are the chelation therapies available? Deferoxamine. Deferoxamine is an infusion. It is available as an infusion. You have to give subcutaneously as an infusion for almost 8 hours, almost 6 to 7 days. So which is very tough, practically very tough for the child. It can have ocular, auditory, and bone growth problems. Okay, and then you have your deferasirox. Deferasirox will have the renal toxicity, as well as it increases the transaminases, so liver toxicity, and sometimes the kidney. So increased creatinine also can occur. Deferriprone is also an oral. So deferasirox is an oral. Deferriprone is also oral. The main complication is your agranulocytosis and arthralgia. They are all orally available. Deferriprone is more often used for the cardiac and chelation. So the oral, remember, has to be taken in the empty stomach, dissolved in water. And there is a concept of dual chelation also, where you combine one along with the other. So remember the shuttle hypothesis, where one acts intracellularly, the deferriprone. Deferasirox acts in the extracellular. So you can use both. So deferriprone for intracellular and deferasirox in the extracellular. This is called the dual chelation. Okay. Sometimes we use hydroxyurea, especially in thalassemia, intermediate or non-transfusion dependent thalassemia, where it increases the hemoglobin F. And is there a permanent cure available for thalassemia? Yes, a permanent cure is available. It will be sibling matched hematopoietic stem cell transplantation, and usually it is done below 14 years. Okay, and it is a good cure available for thalassemia major. Coming to points about non-transfusion dependent thalassemia and other problems. Non-transfusion dependent or thalassemia intermedia, here some amount of adult hemoglobin will be there. It is just mutated. It is less functional, but it is not totally absent. The adult hemoglobin is, the beta chains are not totally absent. We call that as beta plus plus or beta plus beta zero. In major thalassemia major, it is beta 0, beta 0. So there are no beta chains at all. So here beta chains are there, but they might be a bit mutated. So that's why we call it as beta plus, beta plus. So age of presentation is more than 2 years of age. They don't present at 6 months. Okay. They usually do not require recurrent blood transfusion because they maintain the hemoglobin around 7 to 9. Because some hemoglobin output is there, but the problem is they also do have hemolytic phases. They will have organomegaly, and even though blood transfusion was not given, still they can have iron overload problems. So remember, iron overload can happen even without any transfusion at all. In thalassemia intermedia, they are prone for iron overload. And the blood transfusion complications, they might ask you what are the problems with blood transfusion. So the infection, hepatitis B, hepatitis C, HIV infection, CMV. Then alloimmunization, you have antibodies against, you develop antibodies against the blood products which you are giving. So alloimmunization. And you have non-hemolytic febrile transfusion reaction. So you have febrile transfusion reactions also possible. So best way to solve is to give leukocyte reduced packed RBC to reduce this alloimmunization, to reduce the CME. So to give the leukocyte reduced packed RBC. So what do you mean by hypersplenism? Whenever the blood requirement is more than 250 ml per kg per year, which is almost like you are requiring more frequently than monthly blood transfusion, then it is called hypersplenism, which is an indication for splenectomy. Okay, so remember in thalassemia, splenectomy is for reducing the number of blood transfusion. Whereas in spirocytosis, splenectomy is for the cure. And before splenectomy, remember the organisms for which vaccinations you have to give, the encapsulated organisms. Okay. Other hemolytic anemia, sickle cell anemia, is not transfusion dependent. So remember, sickle cell anemia, it's hemolytic anemia, but it's not transfusion dependent. You may give blood transfusion only if there is CNS symptoms like recurrent stroke. To prevent that, you can give transfusion. They don't have splenomegaly at all because autosplenectomy happens because of the crisis, splenic crisis. No, so they will have splenectomy, autosplenectomy. They present mainly not as paler, not as they present mainly as crisis symptoms. They have the pain crisis, hand foot pain crisis, aplastic crisis due to parvovirus infection, acute chest syndrome. So all these crises only they present. They don't present as paler and jaundice. They present as crisis. Okay. And G6PD deficiency. So the presentation will be a boy child presenting with hemoglobinuria. So they have this reddish color urine because of the intravascular hemolysis. They also have jaundice and pallor. This is precipitated typically because of the drugs, commonly because of drugs or infection. Common drugs they might ask you: NSAIDs, primaquine, chloroquine, vitamin K, and sulfonamide. And hereditary spherocytosis, they present with jaundice right from the birth. It is an autosomal dominant, so family history can be there. Family history of gallstones can be there. This child also can have gallstones. Jaundice is markedly present in spherocytosis, and splenectomy is almost a cure for spherocytosis. So, to finally, to before wrapping up, what is the approach to a child with hemolytic anemia? So, make sure whether it is an acute onset severe pallor with a red or brown colored urine, or is it a chronic pallor with no reddish or brownish discoloration of the urine? So acute onset of pallor with red color urine means it's probably acute intravascular hemolysis, as in G6PD deficiency. If it is a male child, it is G6PD deficiency. If any sex with a recent viral infection, Coombs test is positive, then it's probably your autoimmune hemolytic anemia. So acute onset of severe pallor with red color urine is probably G6PD deficiency or autoimmune hemolytic anemia. Chronic pallor with no reddish brown discoloration of urine on regular transfusion, as in our case, every 3 to 4 weeks since infancy, it is probably thalassemia major. Needs an occasional transfusion, then it's probably hereditary spherocytosis, or it could be thalassemia intermedia also. Okay. Thank you for your patient listening. Okay.